Welcome back from your break. We're going to continue our discussion of vasculitis and going from large vessel disease to smaller vessel disease. And my focus won't be to try to tell you about all of the different small, medium-sized vessel forms of vasculitis, but to focus on two areas where there have been dramatic breakthroughs. And this is under the rubric of what we call ANCA-associated vasculitis, or anti-neutrophil cytoplasmic antibody-associated vasculitis. And that includes mostly two diseases. We used to call it Wegener's granulomatosis. We now call it granulomatosis with polyangiitis, or GPA, and microscopic polyangiitis. The ANCA thing, that antibody, anti-neutrophil cytoplasmic antibody, it tends to confuse some people. If you look at it by indirect immunofluorescence, there are several patterns that you can see. One is perinuclear, that we call P, and here you can see the antibody and fluorescein tag produced label only is bright around the nucleus of the neutrophil. Whereas here in the C pattern, this coarse granular material is the cytoplasmic ANCA, but sometimes you can see some staining that isn't typically looking like either one of these, and we just call that atypical. Now, in the case of GPA, Wegener's, 85 to 90% of patients will have antibodies to proteinase 3 that produces this cytoplasmic pattern. And among those people who are ANCA positive, 20% will, with Wegener's, will make antibodies to myeloperoxidase. So let me restate that again. 85 to 90% of patients are positive, and among those who are positive, 80% of them will be C-ANCA positive, 20% will be P-ANCA positive. So you can have this clinical phenotype of disease, but not necessarily have the same ANCA pattern. Now, for myeloperoxidase, it breaks down similarly. About 80% of people are positive for ANCA, and if you're positive, you're going to be, in this case, perinuclear ANCA positive, with your antibody being directed principally to myeloperoxidase. Now, Churg-Strauss is sometimes included within the ANCA-associated vasculitides, and the new revised nomenclature by the Chapel Hill Consensus Conference that I was a participant in voted to include Churg-Strauss. But bear in mind that only 40% of people with Churg-Strauss, in the best studies that have been done, are ANCA positive. Most of those are anti-MPO positive. The percent goes up higher if you have glomerulonephritis. So it suggests that ANCA might be playing a role in causing kidney targeting more often than not. So it's a very useful diagnostic tool, but I'd want to remind you, without taking you through all the literature, that it does not correlate very well with disease activity. So in our clinical practice, we do not follow ANCA sequentially as a measure of disease activity, although we do include it in our formal studies because there isn't an international consensus on that. A lot of people have the misinclination that PAN, polyarteritis nodosa, is an ANCA-positive disease, and it is not. It is not. It is different from these because those diseases that I just mentioned, GPA, MPA, and Churg-Strauss, they're small and medium-sized vessels, whereas PAN is strictly a medium-sized vessel disease, and it is not ANCA positive. It is not associated with glomerulonephritis or pulmonary hemorrhage. So if we were to then draw up the prototype of Wegener's granulomatosis that we now call granulomatosis with polyangiitis, GPA, essentially any organ system in the body can be affected, but the classical phenotype is to have involvement of the upper airway, the lower airway, and the kidneys. But in fact, any place in the body can be affected. One of the important characteristics of Wegener's is to have mass lesions. And mass lesions can also be present in essentially any organ in the body. And I list just 8 here that are noted more often than others, the most common being mass lesion pulmonary nodule in the lung, orbital pseudotumor, and so on, but can be seen almost anywhere. The other important characteristic is what I've just told you about, and that's ANCA, which in the case of GPA is mostly proteinase 3, antibodies to proteinase 3, not MPO, except in a very small number of patients, less than 20%. So how do we then distinguish GPA from MPA? Well, in these yellow highlighted boxes, we can see upper airway disease, nodules, mass lesions, and tubular airway involvement. All distinguish GPA from MPA. In Wegener's, we get vascular targeting and injury, but we also get injury to the parenchyma of organs outside of the vessels. Not so with MPA. That's strictly a vascular disease. And when you look at the histopathology, it differs also that in Wegener's, or GPA, it's granulomatous, and in MPA, it is not. In MPA, you also have your ANCA targeting principally to myeloperoxidase and not proteinase 3. So here I'm showing you a picture of diffuse pulmonary hemorrhage, an immediately life-threatening complication of vasculitis. And I'm also showing you a picture of crescentic glomerulonephritis. This is one glomerulus that I'm outlining here. There's a lot of interstitial nephritis as well. So when I show you that and I say, what could this be? You should say, well, this is pulmonary renal syndrome. It could be within the confines of vasculitis. It could be GPA or Churg-Strauss or MPA. But if there's granulomatous changes, not MPA. It's only GPA and Churg-Strauss. Those are the two granulomatous forms of ANCA-associated vasculitis. Now, if we add to that clinical phenotype that your patient has asthma and eosinophilic granulomatous changes, the diagnosis is only one thing. And here you can see the eosinophils within the lung biopsy. That diagnosis is only Churg-Strauss. There's no differential. Now, the most important thing I want to share to you about this group of diseases is how treatment has changed in the last 10 years. And I've given you a few critical references here to look at as well. So the state of the art, I can tell you unequivocally, has changed for the treatment of these diseases. What we used to do, what we were guilty of doing many years ago, we don't do that anymore. And these are the studies that led to change. So cyclophosphamide, great drug to induce remission in all small, medium-sized forms of vasculitis. And the question that's been asked is, once you induce remission in someone who's really sick with Wegener's, GPA or MPA, do you have to keep using cyclophosphamide and buy into all of that long-term toxicity that we know it produces, like high frequency of bladder cancer, lymphomas, other solid tumors, myelodysplasia? Or can you stop the cyclophosphamide at some point and switch off to a maintenance agent and do just as well? So in this very important study from David Jane and the European Vasculitis Study Group, we see patients within this study, 155 patients. These consisted of patients who had both GPA and MPA. The majority was GPA, but a significant number of people with MPA. They all had severe disease. 94% had glomerulonephritis. They were initially treated with cyclophosphamide and corticosteroids. After 3 months, remission was induced. If remission was induced, as it was in most patients, they then got randomized to you continue cyclophosphamide, or you instead get switched off to azathioprine, a much less risky drug, much more benign drug, with a good track record for chronic use. And what we see here is that for the first 12 months, these curves are superimposable. And we're looking here on these curves at maintenance of remission. So at 18 months, we have about 90% of all patients in remission in both groups. Now, knowing the toxicity of cyclophosphamide, the investigators felt it was unethical to keep giving cyclophosphamide in the control group here, so they switched everybody to azathioprine. And at 18 months, again, there's no difference between the groups that started on cyclophosphamide, continued for a year, or was switched off to azathioprine. So what they proved was that you could spare long-term cyclophosphamide use and have good maintenance of remission with azathioprine and have much less toxicity than you would with cyclophosphamide. So then, gosh, what should we use? We've also know about studies where methotrexate has been used for milder features of disease, also able to induce remission without ever using cyclophosphamide even. Should we use cyclophosphamide for induction of remission for very severe disease and then only use azathioprine for that because of that study data? Or should we consider comparing methotrexate to azathioprine? And that's what the French vasculitis study group did. People were induced into remission. In this case, instead of with oral cyclophosphamide, they used IV. And for all people who experienced remission, they were then randomized to get one or the other maintenance therapy. And you can see that over the first 12 months, we're close to what I showed you in the azathioprine study, stepping down from cyclophosphamide, that the European Vasculitis Study Group did. We're at about 90% remission at about 12 months. And both drugs did an equally good job. The thing that concerned me when I looked at this study is what's happening here. Why are people in both groups falling off? Why are they no longer maintaining remission? And you have to go back to the methods to appreciate what was done here. So after 12 months, the doses of azathioprine or methotrexate were tapered and then withdrawn. And so relapses are occurring in large numbers without maintenance therapy. So think about that. You as the patient, would you want to risk coming off maintenance therapy if you were tolerating it well, knowing that once you come off, your risk of relapse increases? Here's another study that asked a question about maintenance therapy with either azathioprine or MMF. Now here the graph goes in a different direction because here we're looking at the frequency of relapses going up the y-axis. So MMF is the solid line, azathioprine the dotted line, and what we're seeing is contrary to what the authors expected. These groups separate here at about 1 year. There's a highly statistically significant difference in outcomes. Many more relapses within the MMF group at 1 year. Very counter to what they thought they were going to see. But my question again when I looked at this study is, why are people continuing to relapse? And here again, the story is the same. At 1 year, both medications began to be tapered, ultimately to be discontinued. So this raises an important question, and that is, do you stop maintenance therapy? Now let's go back. I've just been showing you studies about severe disease, and I'm going to introduce another scenario to you where people with GPA or MPA have milder disease. And the question is, can they get by with a milder approach and not use cyclophosphamide at all? So people designated as mild disease, that is, they don't have rapidly progressive glomerulonephritis, they don't have diffuse pulmonary hemorrhage, they're relatively stable, but they still nonetheless have multifocal active disease. So they are not given cyclophosphamide in one group. They're given only methotrexate. And in the other group, they are given traditional cyclophosphamide. And at 6 months, which was their primary endpoint, there was no difference. So from mild to moderate disease, creatinine not above 2 no pulmonary hemorrhage, methotrexate does as well as cyclophosphamide. So you can, given this data, completely avoid the use of cyclophosphamide for mild to moderate disease. The other part to that study is at 1 year they discontinued therapy in all patients, and the frequency of relapse was dramatically increased. So we know relapses are common after treatment is discontinued from these and other studies, but what we don't know is what is the risk-benefit properties of continuing either methotrexate or azathioprine indefinitely for many years. We don't have that data in this group of patients, but certainly we have data about the safety of methotrexate in rheumatoid arthritis, where we know among people who tolerate it well, who don't have to discontinue it, the safety profile is extremely good, and there's no significant increase in malignancies. Now, biologic agents have also come into the arena for treating ANCA-associated vasculitis, GPA and MPA, and these are two studies that came out in 2010. I was part of this study called the RAVE study, and this is the study that demonstrated that rituximab compared to cyclophosphamide was equally effective in inducing remission and led the FDA to approve rituximab for the treatment of GPA and MPA. And when we look at the data from that study, looking at the probability of remaining in remission over the period of follow-up, we see that over 70% of patients in both groups, numerically a little more in the rituximab group, but not statistically significant, remained in remission, had remission achieved within the 18-month period. Now, rituximab, just like our other therapies, will not maintain remission after one course indefinitely. People will relapse over time, and repeated therapy will be needed in many patients. The question before us now is, should we put patients on rituximab and retreat on a schedule, or retreat only based on indication of relapse, should that occur? Now, no matter what therapy you use for driving people into remission, controlling their disease, saving their lives, who have either MPA, GPA, Churg-Strauss, there is one major concern, and that is demonstrated in this study and this table from the European Vasculitis Study Group, where they combined 4 separate studies. So when we look at all causes of death within the first 12 months of the study, we see that 10%, almost 11% of all patients died. And among those who died, infection was the leading cause of death. This is something that we need to be keenly aware of in treating these people, causing them to be profoundly immunosuppressed, while at the same time we're trying to provide life-saving therapy. The other concern was cardiovascular disease. There's an increase in cardiovascular disease compared to the general population in these folks. And we know that chronic inflammation is often associated with an increased frequency in cardiovascular disease. We've learned that from the rheumatoid arthritis and lupus populations. So your patients should be seeing specialists in preventive cardiology given this disease. Now I'm going to end with a last case. And I'm going to tell you about a 38-year-old man who came to us with profound illness. He started out with ENT, musculoskeletal, and some minor pulmonary symptoms. And this was his chest x-ray when he called his local doctor when he was on vacation in Florida, called one of our doctors here and said, I'm really feeling achy and I've got a cough and my sputum has a little blood in it. He said, well, go to the ER down there, have them check you out. And they did, and they sent him on his way back here. So he drove back to Cleveland, and within a matter of 2 days, he had diffuse pulmonary infiltrates. This turned out to be diffuse pulmonary hemorrhage. He was treated with traditional effective medications, cyclophosphamide, high-dose steroids. He was markedly better. And you could see within a matter of a week, actually this is more a matter of a month, that his chest x-ray cleared completely. So now he's doing well. He's still on cyclophosphamide, taking 150 milligrams a day, 20 milligrams of prednisone. He's on Bactrim for pneumocystis prophylaxis. And now he calls with acute shortness of breath, but he has none of the original symptoms that led him to present in the first place. His creatinine is stable, and the question is, what's going on? Is he increasingly short of breath because of disease relapse, a comorbidity, or drug toxicity? Comorbidity, infection, pulmonary embolus, drug toxicity is this cyclophosphamide pneumonitis. And I'll refer you to a study that we published in the Annals of Internal Medicine in 2005 that emphasizes how incredibly common DVTs and pulmonary emboli are in patients with GPA, and subsequently others have pointed out also MPA as well as Churg-Strauss. So when these people look like they're doing great and they come in with cardiopulmonary symptoms, pulmonary embolus has to be very high on your list. So let's get to the take-home messages of everything that we've discussed in each of these 3 sessions. Number 1, the vessels that are used by white blood cells to traffic throughout your body are not the same in different organs. They're uniquely different in different organs, just as the tissue parenchyma within those organs is different. And in ways that we don't yet understand, that may play an important role in disease targeting and disease phenotype. Number 2, we are beginning to understand that trafficking and also the dialogue that exists within tissues between immune reacting cells, etiologic agents, and tissue substrate. So stay tuned for new discoveries in that area. From a practical point of view in taking care of these patients, I hope you now realize it's absolutely critical, once you've made the diagnosis of vasculitis, to distinguish primary versus secondary. And finally, ANCA is a very useful diagnostic test, but it's a very imperfect test for monitoring disease activity. Also, within the context of ANCA, the diseases that we put under that umbrella are really quite different. GPA is very different than MPA, is very different than Churg-Strauss. And studies of those diseases, from my perspective, should always be done separately, not lumping them together. And I hope, finally, I've impressed you with the fact that treatment has dramatically changed in this area of ANCA-associated vasculitis, and you should never, ever be considering using cyclophosphamide the way all of us used to. We should never be giving it as a chronic therapy beyond 3 to 4 months. I hope that information has been helpful conceptually and in the way you treat patients in the future.